Welcome to my Macular and me. My name is Cathy Elf and I'm the Chief Executive of the Macular Society, and it's great to have so many people again on the call this evening. We've been running these now for a couple of years, really, since the start of COVID, and we never run out of interesting topics, and it's great to see so many people with us again tonight. So last month, if you were on the call of My Macular and Me last month, you'll remember that we were talking about the value of data, especially so-called big data, and its extraordinary powers to help accelerate research and help deepen our understanding and shed new light on our understanding of disease. This month, we're also talking about data, but this time it's data that's in the here and now, data that's intended now to help us improve the care that we already have available. We have just had the first report from the National Ophthalmology Database audit of age-related macular degeneration treatment around the NHS across the UK. Now, this sort of clinical audit is a way to find out if healthcare is being provided effectively and in line with the kind of agreed standards and targets that are set by regulators and by august bodies such as the Royal College of Ophthalmologists. So the data lets hospitals and doctors and indeed patients know when their service is doing well and if any improvement is needed in that service. So the aim, if you like, of clinical audit is to improve both the way that care is delivered and the treatment outcomes, the results that patients actually experience. The AMD audit specifically looks at the way that the treatment of wet AMD is provided across the UK. And it aims to provide the benchmarks for the way that treatment is given and to encourage hospitals to compare their results with those of other units and improve where they need to do so. So the audit has been led by my guest tonight, Martin McKibbin. Martin has been a consultant ophthalmologist in Leeds for more than 20 years. He has clinical and research interests in vascular and inherited diseases of the retina, and he's been giving intravitreal injections for AMD for nearly 15 years. So that's pretty much the whole time that the treatment has been available. He was appointed clinical lead for the UK AMD audit in 2020, and he is an author of the first report. And he's going to be giving us the highlights from that report this evening. Also joining us this evening will be Martin's colleague, Paul Donachie. Paul has been a medical statistician for the Royal College of Ophthalmologists, National Ophthalmology Database for more than a dozen years. He's been responsible for the National Cataract Audit, and many people I know on this call tonight will be as interested in cataract audits as they are in AMD audits. His research interests are in vitreoretinal surgery, and he's previously worked on paediatric oncology cancer clinical trials. And in his spare time, analyses data for a charity that looks after injured and abandoned foxes. I really want to know a bit more about that, Paul. He's also an author of the first report of the National AMD audit, and he'll be able to answer some questions a bit later on about the audit. But first, let's welcome tonight's expert guest, Martin McKibbin. Martin, thank you so much for joining us. Paul, of course, thank you for joining us too. Martin, I'm going to hand over to you straight away to tell us the highlights of the first AMD audit.
Thank you, Cathy. I'm just going to start my slides. Paul, perhaps you can see my slides and I can see you. So can I just check that you can see the title slide?
Yes, we can. Yeah.
Okay, great. Thank you. So thank you for your kind introduction, Cathy, both for Paul and for myself. So my name's Martin McKibbin. I'm an ophthalmologist in Leeds and I'm the clinical lead for the AMD audit. I think I last spoke at My Macular and Me almost 2 years ago when we were just floating the idea of an AMD audit for the UK. So it's great that I've come back perhaps just within 2 years with the first report of the AMD audit, and I'm going to share that with you. So these are my disclosures. I've got some personal disclosures, and perhaps the most important bit is at the bottom. So the College of Ophthalmologists announced a 3-year project to get an audit for AMD established in the UK in April of last year, and that relied on funding from the Macular Society, from industry partners, and participant fees from trusts. So without funding from the Macular Society, this audit wouldn't have got going. And I'm very grateful to all the members of the Macular Society who helped us to choose some of the outcomes for the audit. So I was meant to share the highlight of the first report, but actually there are several reports. If you're struggling to sleep tonight, you could log on and perhaps start peruse the 90-page full report of the AMD audit. But perhaps for a non-clinical audience, the most important reports are the patient summary. So there's a patient summary in a PDF copy, and then for people who use an e-reader, there's also a Word version, and hopefully that'll give you the key results. And it's really those key results that I'm planning to share tonight. So my aim was to there are a couple of introductory slides to highlight audit and to mention about vision. And then I was going to summarize some of the key findings from the audit, talk about data quality, some of the variation in outcomes, recommendations for patients, to talk about what we're planning to do in future years, and then to answer some of your questions. And I may need to rely on Paul's help with the answering of questions. So as Kathy said, clinical audit is a quality improvement tool that the NHS uses to ensure that care is given effectively. And the idea of audit is really to remove variation in care. So if you imagine that you had a group of patients who had the same problem and were treated in the same location, by pooling their data from those patients, you'll start to build up an idea as to how the average person with a particular problem gets on when treated in the same location. So that can be quite useful, but particularly because it will enable you to compare outcomes in one location, such as a hospital, with patients treated in another hospital, or with national standards or with benchmarks. So I'm sure that the audience here is far too young to have fallen and broken your hip, but imagine you had an elderly relative who had done the same. So some of the data relating to care for that person with a broken hip would be saved in the National Hip Fracture Database. So that would collect various bits of data. It would make sure that he or she was admitted to the correct ward, that they were seen by a specialist in the care of older people, that they had the right operation, and that they had that done within the correct time period, and that they're also given medicines to try to reduce the risk of future fractures. In addition, the artificial hip joint that was given to you would have a serial number, and that serial number would be included in the National Joint Registry. So that would ensure that you were given the correct artificial hip, and also if there were problems with that hip, with that replacement hip joint in years to come, you could be contacted to see if you needed any remedial surgery taken. So often your clinical data is collected almost without you knowing it and submitted to Part C's audit, and it's all done anonymously. So none of the data that leaves an organisation about you or one of your elderly relatives is identifying. So you can't be identified as an individual, and the power is in pooling the data from large numbers of people. And as Kathy said, it's really your data, and essentially it's your audit. So it's using the data relating to your care to produce an audit to try to improve outcomes for all patients accessing a particular treatment, in this case, wet macular degeneration, and to remove that unwarranted variation. So the second thing I need to talk to you about was how we record vision. So for most people attending a macular degeneration treatment clinic, they will be familiar with this type of chart. It's an ETDRS chart or a logMAR chart, and it's slightly different to the standard chart that's used at your optician, for example, or in an eye clinic, in that every line has the same number of letters, namely 5, and those letters get smaller as you go down. And typically what we do is we add up all the letters that you've read, and then we give that a score. So later on, I'll talk about what was the average letter score, or what was the middle value for letter score. So that's the first thing. Just remember, it's the number of letters you read. And also I need to introduce the idea about good vision. So there's a cutoff which is almost at the level of being able to drive independently. And I've sort of highlighted it with this red line down at the bottom. I'm hoping those of you with good vision can see that. So essentially that means 70 letters on the chart when read from a distance of 4 meters. So below that would be good vision, and anything that doesn't quite get to that level would be counted as poor vision. So when I talk about people having a good outcome, I'm trying to refer to the eyes that were able to read more than 70 letters or below the red line on this chart. And then the other thing we're going to talk about is people who've got stable vision. So stable doesn't mean exactly the same. It just means a change of less than three lines of letters or 15 letters on this chart. So if you started off in the middle, provided you don't deteriorate by 3 lines, then you've still got stable vision. And if you improve by any less than 3 lines, we'd say you haven't had a significant improvement in the vision. So there are key things. One is the total number of letters you read. The second one is whether you've got good vision and you can read perhaps below the line for those of you who can see it. And then the third thing is about this definition of stability. It doesn't mean exactly the same, but it means fairly close to what you started with. And I fully accept that the number of letters you read doesn't really relate very well to how easy it is for somebody with wet macular degeneration to read a letter or to watch television or to recognizing people across the street. And it certainly doesn't measure the size of a dark patch in your vision or the amount of distortion you've got or how colors vary from the affected eye to the unaffected eye. But for now, it's the best measure of function that we've got. And later on, I'll come back to some of the things that we're planning to do that might help us to capture outcomes and experiences that are important for patients and people who are affected. So we invited quite a number of organisations to take part in the UK AMD audit, and about 75 organisations signed up. And it was great that we got representation from England, from Northern Ireland, Scotland, Wales, and from the Channel Islands. So we genuinely did have full UK coverage. And that included both NHS trusts, so typically hospitals, and also independent sector providers. So these may have been organisations providing private treatment, but they're also organisations that were providing NHS-funded treatment for patients. And although there were 75 signed up, some of them didn't supply data for eyes that started treatment in the year 2020/21, and that was the year we were going to start with. And some of them had very small number of patients. So we ended up with data from 63 sites and looking at eyes that started treatment in the year 2020/2021. And we couldn't have picked a worse year. So that was the start of the pandemic. And really, we have no idea, or we had no idea what sort of effect that would have on the quality of data and on the outcomes of treatment. But anyway, from those 63 organisations, we got data from 18,362 people. And then some of them were just having one eye that started treatment in that year. And some of them had both eyes that started treatment in that year. So we've actually got data from over 20,000 eyes. And while that's not the biggest AMD database, it's one of the biggest. And as I said, the strength of this is partly to do with the numbers and also to do with the fact that we're analysing data that was collected as part of routine clinical care in hospitals, and that's recorded on a computer whenever you come up to the hospital clinic. And because some people had one eye treated and some people had 2 eyes treated, I know that eyes don't get to hospital by themselves, but I'm going to talk about eyes from now on. So I know you might want me to talk about people, but it's going to have to be eyes because I'm going to talk about the 20,000 eyes rather than the 18,000 people. So in terms of the summary results, if you wrote down all of the levels of vision at which I started treatment in this year and chose the middle value, then that middle or median value was 60 letters. So it's not good vision, it's not awful vision, it's somewhere in between. So that was the starting point. And then if you jotted down the median or middle number of injections that those eyes had within the first year of treatment, then the middle value was 7 injections. And we were quite keen to work out how quickly people started their treatment. So for most people, not for everybody, but for most people with wet macular degeneration, their treatment at the time was given with an initial course of monthly injections every month for 3 months. You would have a treatment on one day, another treatment the next day, a month later, and a third injection a month after that. And then based on how I had responded to that initial treatment would determine how often you had treatment thereafter. So we set a target for sites to be giving that treatment within 10 weeks, and 65% of eyes had that treatment completed within 10 weeks. And that figure, if you allowed it to go out to 12 weeks, that figure rose to 73%. And then in terms of stable vision, and I said before, that's not exactly the same, but it's less than 3 lines of letters or 15 letters. So 90% of eyes kept stable vision. 20% had a worthwhile improvement. So that's an improvement of at least 3 lines on that letter chart. And then the proportion with good vision, so I said before, that's close to driving standard, increased from 27% at the start of treatment, and there's a slight error with this slide, it's not 46%, it's actually 41%. So the majority of eyes kept stable vision, a reasonable percentage had an improvement, and then the proportion with good vision at the end of treatment improved. And if you wanted to work out which of the eyes that gets the best outcomes, then we were able to start to dig into the data to work out which of the eyes that will end up with good vision. So if you had good vision at the start of treatment, so that's more than 70 letters on that chart, then more than 3/4 of eyes kept that level of vision at the end of the first year of treatment. However, if you had poor vision, and in this case we chose the definition of 35 letters, then only 5% or 1 in 20 of those eyes ended up with good vision at the end of treatment. So obviously your outcome depends on your starting vision. If you have good vision at the start of treatment, you're very likely to keep it. Whereas if you've got poor vision at the start of treatment, then you're unlikely to get a good vision outcome at the end of treatment. And then we also looked at the impact of age. So for people who were under 70 at the start of treatment, more than 50% of them, or more than 1 in 2, ended up with a good vision outcome. Whereas if you looked at the people who were aged over 85, then only about 1/3 of them ended up with this good vision outcome. So the biggest drivers of your vision at the end of treatment were what was the level you started off with and what was your age. And typically the best outcomes were seen with eyes that had good vision at the start of treatment and in younger people. And the other things that seemed to make a difference was whether it was your first treated eye or your second treated eye. And I think we know that in general, second treated eyes start off with good vision. So that may be because people are aware of the pathway they need to follow to get their eyes or to get some attention, or it could be that hospitals are just geared up to picking up wet macular degeneration in a second eye compared to a first eye. So typically we saw better outcomes with second treated eyes compared to first treated eyes. And then I'll talk later about the fact that there was also quite a bit of variation in terms of your treatment center that you ended up going to. And some centers were very good at getting a large proportion of treated eyes with good vision at the end of the first year, and some were less good. And then in terms of the proportion of injections given by non-medical staff, so when I started giving injections 15 years ago, I was the only person in my hospital, and for a time it was all doctors. And then we realized we didn't have enough doctors to go around, so we started to train nurses and orthoptists, and now optometrists or opticians to do it. So for all of the patients and all of the injections, more than 2/3 of them, 65%, were given by non-medical staff. And actually, we didn't quite know the profession of the person giving the injection for about 6%. So yeah, so that was that. And in general, the treatment was safe. So I know an injection is painful to have, and I wish I could make it better. And I know that the injection is, your eye that's had an injection is painful for the rest of the day. But when we looked at the most feared complication, which is an infection in the eye called endophthalmitis, the risk of that was low. It was about 1 in 6,500 injections. And that means that about 1 person in 1,000 might expect to experience that complication in an average year. So generally, the treatment was safe with a low frequency of serious complications. So those were the sort of key summary findings. And I said we'd talk about data quality. So I always like to think that in Leeds we record our data very effectively, but actually sites are never as good as people think. So Paul and I set a target of 75% for data quality. We thought that was quite lenient, but it was a COVID year, and we were hopeful that we would exceed that. And in general, we did. So in terms of the proportion of eyes that had a vision recorded either at the start of treatment or after 1 year of treatment, it was around about 90%. So that was well above the 75% minimum target. And I think going forward, we're going to have to set not only a minimum target, but also an ideal data quality target. One problem was that for the 20,000 eyes, we lost track of about 12%. So that's more than 1 in 10. And we don't know what happened. So it's possible that some people moved and had treatment provided at a different place. It's possible, given the population, that some of them had died, but that's not very likely. It's possible that had other problems and couldn't come back around the time that their 1 year data was due to be caught. Or it's quite possible that a lot of people voted with their feet and worked out that they weren't getting the improvement they wanted, and that the burden of treatment was not worth the benefits of it. And I suppose the disappointing thing for Paul and I is that we don't have any data for this 1 in 10 eyes, and that makes you always slightly unsure how applicable the results are to the whole group of eyes or patients rather than just to the ones that did complete 1 year of follow-up. And then some of the outcomes that we had planned to look at, one of them where we couldn't capture any data for. So one of them was that we were keen to ensure that most eyes started treatment within 14 days of the diagnosis. And that was a target that was suggested by the National Institute for Healthcare and Clinical Excellence. But in order to work out if treatment was started quickly, you need to know when the referral arrived in the hospital or at the independent sector provider. And it was actually getting data about the referral that proved difficult. Less than 40% of eyes seemed to have a referral date, but that was anywhere from a couple of days earlier to almost 2 years. So probably the referral date didn't always relate to the macular degeneration diagnosis. And when a referral date was available, only about 25% of eyes started treatment within 14 days. So that's something we need to try to work on to improve the accuracy of the data. And then we're also quite keen to look at follow-up delays. So a delay might be because somebody was ill and unable to attend, or because the hospital cancelled the appointment or never got round to doing it. And that was one of the outcomes which was suggested by the members of the Macular Society. And we found it very difficult to analyse the follow-up or the planned follow-up interval. So that's something that we're going to try and work on for future years. The other thing that I touched on was about variation between centres. So the idea of audit is to try to remove the variation so that somebody who, for example, presents to an eye clinic in Leeds might expect to have the same care as if they'd presented to an eye clinic or anywhere else in the country. But unfortunately, we found there was quite a bit of variation between centres for almost every bit of data that we looked at. So I said before that the middle or median starting vision was 60 letters for these 20,000 eyes. But if you compared the middle value between all the different centres, it ranged from 30 letters, which is very poor, to 65 letters, which is obviously a bit better. And we don't know the reasons for that, although we might speculate. And then again, if you looked at this idea of trying to get the loading phase of the 3 initial monthly injections done quickly and within 10 weeks, so the median or the middle proportion was 65%, so 2/3. But if you compared between the centres, it ranged from only 1% up to as high as 92%. So some centres were very good at getting this initial phase of treatment completed on time, and other centres were very poor. And then equally, if you looked at the proportion of eyes that had this idea about good vision after 1 year of treatment, so overall, the figure was 40%, but it varied from 5% in the centres that did less well to 65% in the centres that did very well. And what we'd like to see going forward with the audit is that we improve not only the starting vision in all the centres, but also the way that care is delivered so that we increase the proportion of eyes with a good outcome at the end of treatment. So that's something that we're hoping to see in future years. So in the summary report for the audit, we made a couple of recommendations, both for providers of treatment, for organisations that commission treatment, and also for patients. And my suggestion for patients would be to have a look at the National Ophthalmology Database website and look up data for your treatment centre and make a bit of a comparison with other sites that you know about or with your local centres. So right now you can do that for people having cataract surgery. So for example, if you lived in Leeds, you can go and look up data for Leeds Teaching Hospitals NHS Trust. And then if you know the person who's going to be giving your doing your cataract surgery, you can probably look up their outcome data for that individual. And you can do that for any provider of NHS cataract surgery that's taking part in the National Cataract Audit. So I have to say that the website is currently being updated, and we're not going to have any macular degeneration data on there for at least a month or two, and possibly a bit longer. But in due course, you'll be able to look up the outcome data for your local treatment centre, or for the one that you're going to, and for your neighbouring treatment centres. And you might want to ask them why are certain outcomes less good in one centre than they are in others. And then if you're starting treatment, or if you haven't yet started treatment either in your first eye, or you might be about to start treatment in your second eye, then I think I would ask the person involved in providing your care to give you some information about how likely is your eye to get a certain level of vision at the end of treatment. So as I said before, we know that eyes with good vision typically keep good vision at the end of treatment, whereas eyes with poor vision rarely get to that sort of level. And I think having this information available might help you to make an informed choice about whether to start treatment or whether it might not be worthwhile. And then one of the key things that's come out is around the impact of your starting vision on your finishing vision. So if you're lucky enough that you've only had one eye treated, then I think you need to work out, or to be absolutely sure in your own mind, if you develop any symptoms in your second eye, how are you going to navigate the healthcare pathway quickly so that you can get seen, diagnosed, and start treatment quickly in your second eye. And if you've had treatment in one eye and it's worked or not worked and you're no longer being under review, you need to be very clear about working your way through the hospital system. And then if you're coming up for hospital treatment or to any treatment for your first eye, I would always be asking, how is my good eye? Have I yet developed any signs of wet macular degeneration in my second eye? So we know about 1/3 of people start off with wet macular degeneration in one eye only, then go on and develop it in the second eye. So I would always ask, how is my treated eye doing and how is my untreated eye doing? And are there any signs of wet macular degeneration in that eye? So going forward, we've got a few plans. So we're hoping to get more organisations signed up to the second data extraction, which is planned for May of this year. And often your clinical records nowadays are not written in paper notes, but in electronic notes. So we're trying to work with the providers of the electronic medical records to help sites improve the data quality and to reach this new target of 95% for data quality. And then we're very much aware that the area that needs most attention is probably the variation in starting vision. So I think we need to, I'm pleased that the Macular Society has had an advert on television to try to raise awareness of the early symptoms of macular degeneration and to encourage people to take note of it and take it seriously. I think we need to try to remind optometrists that NICE recommends that referrals for suspected wet macular degeneration should be made within 24 hours. And we need to make hospitals and independent sector providers aware of the fact that they need to have a dedicated pathway for people with suspected wet macular degeneration that allows them to be diagnosed or assessed quickly, diagnosed quickly, and then to start treatment quickly. And hopefully by doing that, we can reduce the variation in starting vision and actually drive it towards the higher end rather than accepting the lower end. And so we had 6 process and outcome measures. And this slide's quite busy and probably quite small. So 3 of them are related to the pathway, so how care was provided, so that's starting treatment quickly, getting those initial 3 injections done quickly, and then reducing the number of follow-ups. And the bits highlighted in yellow are the bits that we haven't really been able to look at in great detail, but that's something we hope to do as the electronic medical records data entry improves. And then there are a couple of vision outcomes. So we want to look at how vision changed and what was the proportion of eyes with good vision after 1 year and then after 2 years of treatment. And then we need to start to adjust for baseline vision and age in order that we can compare an average eye treated at one organisation with an average eye treated at another organisation and work out which organisations are providing the best care and what were the most important parts of the care pathway. And then the final bit is about complications. So I think we're reasonably confident that we've got good data about complications, but I'd like to become a bit more confident that we're capturing all of the cases that have had serious complications after treatment. And then the final bit about going forward is we are very keen to collect some patient experiences and outcome measures. So I did say at the start of my presentation that I was going to talk about eyes, not patients, but actually it's people, it's not just eyes. And I think I'm often reminded that we need to try to provide a patient-centered service to encourage people to attend despite the burden of treatment. And it's important to start to listen to patients' comments and to design your service so it's patient-friendly. So we do need to collect some data about patient experiences and also outcomes. And the Macular Society have tried to do this before. So on the left here, we've got an image that I took from one of the Macular Society surveys that was done in 2020. And it asked members in the last year, how many eye clinic appointments have been cancelled by the hospital? So a good number said none, but about 1 in 16 people had had at least one appointment cancelled, and 1 in 6 had had several appointments cancelled. So it's that sort of information that we want. But the Macular Society survey didn't identify it by your care provider, and I think we need to do that. So people always tell me, and in fact the survey we did with Macular Society members reminded me that accessible parking is key, that getting written information about the diagnosis and treatment is important, that people want early access to an eye clinic liaison officer and to low visual aids, and they need to get their appointments in time. I was very struck by the fact that everybody said, we've got a life to live, we can't be waiting at home for an appointment to come through. So we need to get it with enough notice, and also we need to get it on time without delays. And these are the various aspects of care that I think we should look towards collecting to try to make sure that services are patient-centred. And other national audits have done it before. So the one I often quote is the National Early Inflammatory Arthritis Audit. And they're very good at collecting patient experiences, which means how was their care provided, and also outcomes. And that would be relevant to how much difficulty you have with reading, watching TV, recognising faces. So they do this every year, and in most years they get about 10,000 patients to sign up and to report their experiences of treatment and outcomes, both at the start of treatment, after 3 months, at the end of a year. So they can get data from at least 10,000 patients. They've got 50,000 patients signed up overall, and that covers 96% of hospital trusts providing treatment. And the way they've done this is to have a dedicated website for the arthritis audit with videos that have been designed by patients to inform other patients. And I think that's something which we're going to look towards trying to do. And I'm currently involved with Julie Hepeshi, who's a colleague from Gloucester, and we're trying to work out what are the questions we need to ask. And probably we're going to refine that with members of the Macular Society, and I need Kathy's help towards doing that. So I know that Twiggy is now the poster girl for the Macular Society, and that all you've had to look at is me and perhaps Paul, and I'm not sure if you can see Paul, so, but I'm sorry for that. But anyway, Twiggy can't give this presentation. So before I finish, I need to thank Lynn and Beth, who are our colleagues at the Royal College of Ophthalmologists, because they've helped to get the AMD audit up and running. I need to thank Paul, who's here tonight, Marta and Charlotte, who are the statisticians at the National Ophthalmology Database. To thank my clinical consultant colleagues and other members of the multidisciplinary team and the audit advisory group, the Macular Society staff and members, because without their funding we couldn't have got to this stage, and also the members who helped us to produce our outcomes. And then don't forget, it's your data and your audit, it's not mine. So thank you very much for listening. Paul and I are going to be very happy to take any questions, and I shall try and answer those as best I can. So I shall stop sharing my screen.
Thank you very much, Martin. That was brilliant. That was brilliant. And how incredibly interesting. The differences are very striking in some areas, aren't there? If you've got any questions, do please put them in the chat, and we'll come down to as many as we possibly can. I'm going to take the questions that directly relate to the audit first, and then if we've time for the more general questions, then we'll certainly come on to those if we can. There was one question for clarification in the presentation about the letter chart and what the red line indicated. Was that the driving level vision, roughly, the red line?
So the red line was meant to be, if you could read below the red line, then your eye met our definition of good vision. And that's close to driving standard. So it might be just not quite driving, but it's getting close to driving standard. So anything, if you read more letters than that red line, then you were considered to have had a good outcome at the end of treatment. So that was the idea. Right. And the total number of letters you'd need to read that would be 70 letters. 70 letters.
So you needed to be able to read below the red line, basically, to
have a good outcome. Now, that was just our definition. It may be you were absolutely delighted with the outcome of treatment, but you didn't quite get there. You might have been one letter less. But if your eye had one letter less, you wouldn't have met the definition of good outcome that Paul and I chose.
I see. Okay.
Hi, Martin. The question was more about if there's 5 letters on the line, you read 8 lines, that's 40 letters. So how do you get to 70?
Okay, so I did say that this would be read at 4 meters. So there's a bit of a conversion factor. So normally you would test somebody's vision at 1 meter to make sure they can read a certain distance down the chart, and then you'd repeat it at 4 meters. So on that chart, if it was tested at 4 meters, there'd be a correction factor of 30 letters to add on. So you would be given the 30 letters, and then you would actually read 40 letters. So it would be 8 lines on that chart plus the free 30 you've been given before.
I see. Okay. All right. I hope that answers that that particular question. So now this, of course, is about wet AMD. We've had a couple of questions about whether there are any lessons that can be drawn out for either dry AMD or indeed myopic macular dystrophy, maculopathy, myopic maculopathy. Are there any extrapolations that can be done, or can we just only really refer to wet AMD with this information?
Well, I suppose the fact we've got a report shows that within the NHS we can actually collect big data sets that we can analyse in a meaningful way. So that's something that we could extrapolate, for example, to the treatment of dry AMD if it became available under the NHS. Or we could extrapolate to the treatment of diabetic retinopathy, for example, but obviously it would need funding to do that. So that's probably definitely relevant. And then I guess the difficulty about this, the time point we chose, is that it was the start of the pandemic, and the pandemic will have affected different units in different ways. So I'm sure that the sites that might appear to be providing less good or less effective treatment here were probably very much aware of the fact that they had particular difficulties that may have impacted on their treatment, or it may be that only started to collect patient data in an electronic record and they have had a very small number of eyes. So I don't think you should draw too many conclusions from this first year about a unit being very good or a unit being very bad, and that's mainly around the impact of the pandemic, and we don't know what that organisation was doing. I think, but where am I going with this? So yes, we can definitely produce a report. So we could collect data, meaningful data, to justify expensive treatment for other conditions. I think we're starting to work out there are some units which seem to be getting good outcomes and some units which seem to be getting bad outcomes. But you couldn't immediately extrapolate this data to the treatment of of myopic macular degeneration, or to the treatment of dry macular degeneration directly. Is that fair, Paul? Would you add anything to that?
No, I think that's comprehensive.
Okay, that's really helpful. Thank you very much. So you've been injecting people for 15 years, Martin. Is it not a bit surprising that it has taken this long to get any sort of audit data on this treatment? Is that a fair question? Fair point?
Yeah, I guess it's a fair question. So within our electronic record in Leeds, we've been able to collect data for all the eyes, all the patients treated in a given year, and we've been able to compare that with 1 year compared to previous years to see, are we in a steady state, are we improving, are we deteriorating? So that's something which I think I've done every year for at least 10 years, and I think other units have done. I guess the difference now is that we're starting to be able to compare how treatment has been provided in Leeds with treatment, for me, with treatment in Harrogate or York or Bradford or Calderdale. And I would like to think that Leeds is absolutely fantastic, but of course I've never been able to do that because nobody's wanted to share their data with me. And I think that's the big thing, that we're now in a position of being able to to compare our outcomes locally with other units. And I think that's the strength of audit. So I will certainly go away and look and see how Leeds is doing compared to my peers. And I suspect all the other units will do the same. And going forward, I'd like us to all improve, not just for Leeds to become the best of the sites in West Yorkshire, but for all the sites in West Yorkshire to improve, and for everybody nationally. And why it's taken that long, I'm not sure, Kathy. You'll know about the funding. So it's not cheap to do this. It costs quite a bit of data quite a bit of money to extract the data from the electronic medical records. It costs quite a bit of money to analyse it with the statistical team that Paul leads. And it costs quite a bit of money to run the project delivery team. So it all costs quite a lot of money, and I think it's due to the cost that it's taken some time. But I take your point. You could say it should have been up and running 10 years ago, particularly given the huge cost of treatment, not only for macular degeneration, but for all the other retinal diseases. So yes, perhaps it should have been done 10 years ago, but it wasn't. However, we've definitely got it started now.
Yeah, well, that's great. So let's crack on with some of these questions then. So one question here is, do we know how often hospitals gave injections at the time specified by the clinic doctor, Can you tell that? And a secondary to the same person, is there a difference in the outcome between eyes with occult neovascularization and manifest? Now, that's a bit of a technical question, but can you help with either of those two?
So I can definitely do the second one first, and then you might have to remind me about the first one. So often the term occult typically refers to a certain appearance of wet macular degeneration on a fluorescein dye test. So on a fluorescein dye test, in general, there's occult and there's classic, and those terms have slightly been replaced by type 1, type 2, type 3. So we know that type 2 wet macular degeneration eyes typically deteriorate fastest without treatment compared to type 1 and type 3. So there is a difference in terms of the outcome and the benefits of treatment between eyes, depending on how you classify their wet macular degeneration. And the ways you can do that are either based on a fluorescein angiogram, which we used to do all the time, but we're doing less and less of now, or whether you do it based on your overall clinical assessment. So there is a difference. Within the audit, we didn't capture the type of wet macular degeneration at the start of treatment, mainly because I think that's not very well recorded. We did capture the diagnosis, but we didn't capture the subtype, and that's something which we might be able to do going forward. I suspect there will be some units where it's very well captured and other units where it's less well captured, and we could look at classic and occult, type 1, type 2, type 3, but we're not doing that just at the moment.
So the first question was, did you record how often hospitals were giving injections at the point the clinician said they should be given, or advised that the next injection was needed? Okay, so one of the outcomes, we had 6 key outcomes, and partly we had a long list from the advisory group for the audit. So that was made up of consultants like myself, opticians, nurses, and other healthcare professionals. And then when we went back to the Macular Society, we managed to reduce that long list from, I think it was more than 10, down to about 6. And one of the ones that the Macular Society members were most keen on was the idea about not having delayed treatment. So if somebody says come back in 6 weeks, it was how good were providers of care at giving that treatment in 6 weeks compared to 8 weeks or 10 weeks or 12 weeks. So that was something we were very keen to do. And actually there is quite a bit of data to suggest that's important. So if your care is planned at 6 weeks, but it's not delivered for 10 weeks, then probably you're going to get a worse outcome than if it was given on time. So that's one of our key outcome measures. But the data that we got around that was quite difficult to understand. And in the end, we gave up on it. So Paul and I have had some meetings with the electronic medical record providers to try to understand that a bit better. And we're hopeful that for the second report, we'll have some more reliable data out that. So the pathways we know so far that get the best outcomes are starting treatment quickly, getting that initial loading phase of 3 injections done quickly, and then not having delays. So trying to minimize the delays. We know that those are the 3 things that definitely seem to affect how your eye is going to respond to treatment. And we want to improve the pathways and get the best outcomes. But this year we couldn't really make head nor tail of the data. And some of that might be to do with the fact that some sites provide a one-stop treatment, whereby you get your assessment and your treatment on the same day, and other sites provide a 2-stop treatment where you come back, you have an initial assessment, and then you're booked in for an injection with a follow-up interval subsequently. So I think we're going to be in a position to better understand the follow-up interval and to try to see what is the impact of delays going forward, but we weren't able to do that in the first report. We know, don't we, that I mean, all our experience tells us that not only patients like to have less good outcomes if they're visual outcomes if their treatment is delayed, but it's also a source of enormous anxiety and great distress to patients when they know that they're supposed to be having an injection and they haven't got an appointment. It really is a very stressful time for them, isn't it? Yeah, I can remember that of people when we did the survey before, that people saying that they're waiting around for the appointment to come. They've got a life to lead. They can't be sitting and waiting for the possibility they might get an appointment on Monday, Tuesday, Wednesday. And then it was very clear about the delays. If we want to find a patient-centered service, we need to make sure we get the appointment letters out in time and that they're not delayed. I think that's the important thing. Paul, would you have anything to add about the follow-up delays and how confident you are that we'll be able to make sense of those next time?
Yeah, just say there's going to need to be some improvements in the systems that are collecting the data. and hopefully this audit will lead to that. So from the experience from the cataract audit, we've noticed in the first 3 years of it significant improvements in the quality of the data that has been collected, but also a significant increase in the number of centres who started collecting data and submitting it to us. So just back to that question about why it's taking so long, one reason was that from 2015 onwards, there's been a lot more hospitals get the actual systems to collect data electronically in ophthalmology, and before that there was really only a certain number who had the systems. There is actually a question related to that, to do with someone who's talked about Fife and paper records. In Scotland there is a program at the moment to supply where a data collection system is being built and will be supplied to all the hospitals. So that's currently underway. So not all hospitals in Scotland do have the ability to record data electronically yet, but they will do. And when they do, they will be submitting data to both the cataract and the AMD audit.
That's good. Yeah, that's great. It is surprising that so many hospitals still don't have full electronic records, isn't it, really? So another slightly technical question has come in about whether the different treatment centres, do they use different, cheaper protein for injections? Is this reflected in the outcomes you measure? I don't understand that question. Perhaps you can help me.
Sorry, Kathy, just ask me the question again.
So this is a question where different treatment centres use cheaper protein for injections. Is this reflected in the outcomes?
So I guess it might relate to the cost of medicines. So at the moment, most, I think, NHS providers use licensed therapies. So that the names people might recognise would be Lucentis or ranibizumab or aflibercept or Eylea, and a new one is faricimab or Vabysmo. So those drugs are, I guess there's a discounted NHS price, but there are also biosimilar drugs. So often if you start off as a drug company, you have 10 years when nobody else can make a similar product. And then when that patent runs out, other companies can make a copy of it. So I guess it's a bit like having Marks and Spencer's beans versus Tesco's beans. Essentially, it's the same thing. It might have come from the same factory, but it's believed to be almost identical and a lot cheaper. So we've had what's called a biosimilar, which is a new type of a particular product, of a biosimilar of ranibizumab, available since I think probably last summer. So that's available. And I suppose the other thing that the question might be related to is Avastin. So Avastin is not it's a licensed product, but it's not licensed for use in macular degeneration. I don't remember how commonly used that was within the audit. Paul might have that data. So far we have been resistant to start to compare outcomes with one drug compared to another, just because I think there's actually more variation. More of the variation in outcomes relates to how care is provided into the starting vision. And I think it's unfair for us to start to say, actually, eyes treated with this drug did better than another drug, because the eyes treated with one drug and compared to the other, they didn't have the same vision at the start of treatment. They weren't treated in a different way. So we're very reluctant to start comparing outcomes with one type of treatment compared to another, because there's so much variation in how eyes were treated between centres. And I can see Paul's definitely looking at something, so I'm not sure if he's going to tell us how many, what proportion of eyes were treated with which drug in this year.
Yeah, we have put that into the report. So hang on, right? So 73.8% were treated with aflibercept, which is Eylea, 23.5% with ranibizumab, which is Lucentis, 2.7% with bevacizumab, which is Avastin, and less than 0.1% with brolucizumab, which is Bevo. Yeah, so one problem with injection results splitting is just the predominance of one particular drug that would swamp any results.
So I suppose at the time, Kathy, that was in 2020/21, there were two drugs that accounted for the vast majority of treatments. When we get around to looking at this year, we'll now have 1, 2, 3, 4, 5, 6 licensed drugs and Avastin, so it's going to get even more complicated to try to work out is one better than other. Probably if you ask me, then
variability for how often people can get the treatment within 10 weeks. What was it? It was something like between 1% and 92%. I mean, that is such an enormous difference, isn't it?
It is a big difference, and I think it's trying to work out. There's probably more to gain by focusing on how care is provided and trying to remove the variation in that than there is about telling people to use one drug over another. I think that's often down to the individual clinicians involved. If there is a difference in the drugs, it might be in terms of how long they act and how much treatment is given, rather than the fact that eyes typically get a better outcome with one drug than compared to another. They might just have less treatment with one drug compared to another one, or more treatment with another.
A question here about NICE standards. Do NICE standards for the start of treatment impact the audit results negatively by worsening the start position? So I think this is a reference to the rule that people can't be treated until they've actually got borderline driving vision. So this 612 entry criteria for treatment, which is basically driving level vision, isn't it? And we've certainly wanted treatment started earlier, because everything shows that the earlier the better the vision when you start, the better the vision when you finish. So do you see that as a problem for this?
So probably I can't quite remember when NICE changed its position, but you're quite right that in the beginning NICE said you could only access treatment for wet macular degeneration if your vision was worse than 612, which happens to be our 70 letters, and better than 696, which was 35 letters. But then subsequently NICE relaxed the position and said that there may be circumstances when actually starting off treatment with better vision than that, or worse vision than at the lower end, would be relevant. So locally, we've tried to sort out the policy in West Yorkshire so that everybody can start off treatment with any level of vision when it's appropriate to do so. So typically we want to pick up signs of progression. So we're not going to say you've got wet macular degeneration, it's not changing. There's no point necessarily in treating it then. But if it's deteriorating, that's the point of intervening. So I'm not sure what, so locally we've removed variation in terms of access, but I honestly can't remember what was relevant at the time. And I suspect there were probably some units which were still abiding to this threshold that they could not start treatment until the vision had dropped below a certain level. And that might be why some of them seem to have more eyes with poor levels of vision at the start of treatment than, and in turn that will impact on the proportion of eyes with good vision at the end of treatment. But in general, I think most units are no longer restricted to this 612 to 696 or 70 to 35 letter cutoff. I think we're now allowed to treat better than 70 letters and below 35 letters when it's appropriate to do so. And I think that's a discussion to have with the patient.
Very much so. That's very encouraging. Question here: how many years of treatment do you intend to cover? So this person has been treated for wet macular degeneration since 2017. It would be interesting to see long-term results. So how many years of this are you going to go on for covering?
How long is it going on for? I'm not sure. So what we've done so far is we get 1 year result for eyes starting treatment in 2021. In the next report, which should come out by the end of this year, we're going to look at the same 12-month outcomes for eyes starting treatment in 21-22, but we'll also get 2-year outcomes for the initial eyes. And then if I can persuade Paul and his team to do it, then we might start to collect 3-year outcomes and 2-year outcomes and 1-year outcomes. So I think it's something that we should be doing. We should be looking at long-term outcomes, but I think we know that the proportion of eyes that get to 2 years drops off significantly, and probably the proportion of eyes that are still having treatment at 3 years drops off again. So while it's important to do, I'm not sure about what sort of data quality we'll end up with. But I think we should look at long-term outcomes, because it may be actually that there is some difference in long-term outcomes between treatments. So I think it's something we should definitely do, again, just to justify the huge cost of these medicines. Yeah. I mean, that's it. They are very costly, and you want them to be as effective as they possibly can be. If you're going to spend all that amount of money. Question here: government's talking about reducing bureaucracy. Will that stop data recording? Do you think you'll find, I mean, the government aren't funding this, are they? So
no, the government are not funding this, and that's another reason why it's taking so long, because we were trying to, a few years ago, get NHS England to fund it, but they said no. I have answered this in the chat, but I think that electronic medical record systems are actually a big help in reducing bureaucracy, because they're used in real time, and one advantage is that the clinical staff can see not just what they're putting on the system for you today, but what they put on the system for you in your previous visit, and your visit before, and your visit before. They don't have to make a call to get someone to bring the paper notes in and then have to go through page after page after page to work out, right, you had this VA on this date, and now flick a few more pages and have this on this date. They're a big aid to clinical staff, and in a proper functioning clinic, they can speed things up so that you can actually have your time in the clinic shorter. They're a wonderful thing, and there is a lot of development going on in the NHS at the moment to do with electronic data collecting, not just in ophthalmology but other eye diseases. And the optimistic part of me would say that's what the government are referring to when they say reduce bureaucracy. The pessimistic part of me would say they're referring to something else. But I don't use these systems, but I get the data from them. And I, years and years ago, did work on a ward and had to record in paper notes. And I would say that the era of recording the paper notes will be gone in a few years' time. And one thing that certainly helped that was the COVID virus, because you had places being told, no, you can't have paper notes in that area anymore. They're a health risk.
Yeah, it's very interesting. So question here, please do record patient experience and patient views about what would make treatment for wet AMD less stressful. So recording these patient reported outcome measures are really vital, aren't they, to the holistic understanding of the service that's being provided.
Yeah, I mean, I'm keen to do it. I think Julie and I are trying to work out what's the best way of collecting it, and also what are the best questions to ask. So at the moment, we've sort of got a very long list, and I think we might need to come back to ask for your help, Kathy, and for the help of the members to try to refine that list. And then, because it's going to be a research exercise, we're going to need to apply for some NHS research funding. So it might take a bit of time to do that, but I think we'll get it done in the end. Paul might provide a bit of an update about the cataract audit. So within the cataract audit, there's there is already collection about patient-reported outcome measures. So under that, you're asked about how much difficulty do you have doing a range of daily living activities, both before the surgery and then after the surgery. And that's a way of trying to show the impact of cataract surgery, not only on your first eye, but also on your second eye. So that's something that's happening at the moment. And then I think what we'd like to do is to start to collect that for AMD treatment, but rather than collect it for all the people having treatment, we want to start to look at it by centres, because it may be that some centres are providing absolutely fantastic, very good patient-centred care, and it may be some have gone for the factory model whereby they're getting through very large numbers of people, but getting through the numbers, but not necessarily providing very holistic care. And I think that's what we'd like to try and strike a balance between efficient services and yet ones which retain a focus on the people accessing the service.
Ultimately, I guess there's got to be some really big questions asked about, why this variation is there, and how the gap can be narrowed, particularly with these extreme ends of things. Why is it possible for one hospital to get 95% of people through the first injection process, and another hospital can barely manage 2%? It's a conundrum, isn't it? We haven't got time to talk about it now, but it's a very big question. I think for some places are going to have to look at and ask themselves some hard questions about how it is that. Yeah,
and I think I don't particularly want to start hounding the sites that appear to be less good, because I'm sure a lot of it was related to COVID. So COVID had a huge impact on the provision of wet AMD treatment, and I think some sites probably cope with that a lot better than others. So I suspect that's one of the big factors. And the other thing will be, as Paul suggested, whether they might have just started to get an electronic medical record and perhaps it wasn't well captured in the electronic record at the time. So I suppose if I was on the site that only did it at 1%, I might have to stop and think, did that really reflect what we were doing at the time? And actually then look and see, okay, have we improved on that? Were we doing better next year? And what are we doing now? Are we still very poor, or were we actually doing much better now compared to how we were doing?
Okay, well, look, we're running out of time, I'm afraid. And you can hear my next meeting has already started. The alarm is chivvying me up. So we're going to have to wrap there. I'm ever so sorry. We've got lots and lots of questions in the chat. We will be able to come back to some of them another time. If you've got questions about your own condition that you want some advice on, please do phone our advice line in the morning from 9 o'clock, 0300 30 30 111, 0300 30 30 111. It's the numbers on our website. We've recorded this session and it'll be on the website fairly soon, so you'll be able to see it again or recommend it to other people if you think somebody else might like to hear about this. And of course, all our webinars, My Macular and me, are on the website if you'd like to revisit any of those. Paul and Martin, thank you very much indeed for your time this evening. It's been a really interesting session. I'm sorry we didn't get to all your questions, but thank you all very much indeed for joining this evening. Next month, we will be talking about zebrafish and how zebrafish might be able to help us understand more about how the human macula works. That's next month's My Macula and Me on zebrafish. Paul, Martin, again, thank you so much for joining us, and thank you to everybody who came on the call this evening. Have a very good evening, and I hope to see you next month. Thanks very much.